Imagine for a second that you're walking around every single day, just, carrying a water balloon.
Right.
And it is filled right up to the breaking point. But you have to pretend to the rest of the world that everything is perfectly fine.
Which has to be completely exhausting.
It really is. I mean, you can't laugh too hard at a joke. You can't sneeze without crossing your legs. You definitely cannot go for a run or lift a heavy box or, jump on a trampoline with your kids.
Yeah, those everyday things just become impossible.
Exactly. And up to 50% of females worldwide live with this exact reality. It's called stress urinary incontinence, or SUI. And despite how incredibly common it is, it remains a condition that millions of people just suffer through in total silence.
It's a massive quality of life issue, really.
Yeah.
Because of the stigma attached to it, many people just assume it's, well, a normal part of aging.
Right, or they think it's just an inevitable consequence of childbirth that they simply have to accept.
Exactly. But from a medical standpoint, that is absolutely not the case.
Yeah.
The treatments available today are highly effective, and honestly, they're mechanically fascinating.
Well, welcome to the deep dive. Today, we are examining a huge stack of clinical guidelines, medical journal articles, and urology clinic resources.
We've got a lot to cover.
We really do. We're exploring what is widely considered the gold standard surgical treatment for stress urinary incontinence, which is the sling procedure.
Yeah, the sling is huge in urology.
It is. And specifically, we're on a mission today to answer a crucial, highly requested question from you, the listener.
And it's a great question.
Yeah, the question is, can a sling procedure be performed under local anesthesia with sedation, or is general anesthesia an absolute requirement?
It's something that causes a ton of anxiety for patients who are considering the surgery. Nobody really wants general anesthesia if they could avoid it.
Oh, for sure. So what's the verdict?
Well, the answer isn't just a simple yes or no. It depends entirely on the specific type of sling that's being used. Yeah, to really understand your anesthesia choices, we have to look closely at the mechanics of the surgery itself.
Okay, let's unpack this. First, I think we need to establish what is actually going wrong in the body to cause stress urinary incontinence in the first place.
That's a good place to start.
And just to be clear for everyone, we aren't talking about emotional stress here. We're talking about physical, mechanical stress.
Precisely. It's all about intra-abdominal pressure. Normally, your pelvic floor muscles and your urethral sphincter, they work together like a highly coordinated valve system.
Okay.
So when you cough or sneeze or lift something heavy, the pressure inside your abdomen spikes significantly. In a perfectly functioning system, that valve squeezes shut tightly enough and quickly enough to counteract the pressure.
Which keeps the urine securely inside the bladder where it belongs.
Exactly.
But with SUI, that system is failing, right? Like, the support structures are compromised somehow.
Yeah, due to factors like childbirth or hormonal changes from menopause or even just age-related tissue changes, those supporting muscles and ligaments become weakened.
They just stretch out.
Yeah, or the urethra becomes hypermobile, meaning it kind of sags or moves out of its proper position. Or sometimes the sphincter muscle itself just cannot close tightly enough.
So when that sudden wave of abdominal pressure hits...
The weakened valve gives way, and you get leakage.
Which brings us to the sling. I was reading through the surgical descriptions in our sources, and the best way I can picture the mechanics here is literally like a tiny hammock suspended inside the body.
That is exactly the dominant analogy urologists use to explain this to patients. It's a hammock.
Okay, so it's a piece of material just hanging there.
Right. A narrow strip of material placed directly under the mid-urethra, but it does not squeeze the urethra closed all the time.
Right, because that would obviously make it hard to pee normally on a day-to-day basis.
Exactly.
Yeah.
Instead, it acts as a backstop. It provides a firm hammock of support so that when you cough and your urethra is pushed downward by that spike in pressure, it hits the sling.
Oh, I see.
Yeah, it hits the sling, kinks shut, and that prevents the leak.
Got it. So if the goal is just to build a hammock under the urethra, this brings us to the big fork in the road, which dictates our whole anesthesia question.
The material.
Yes, the material used to build it. Our sources highlight two main categories of slings. You've got the autologous fascial sling, which is made out of the patient's own tissue, and the synthetic midurethral sling, which is made out of a pre-made polypropylene mesh.
And those two materials represent vastly different surgical experiences. The material you choose dictates how invasive the surgery will be.
Which directly dictates your anesthesia options.
Exactly.
You know, this sounds like the difference between building a hammock in your backyard using a prepackaged kit you bought from the store versus having to go out into a field, harvest the cotton, spin the thread, and weave the ropes yourself before you can even start building the actual hammock.
Yeah, that's actually a really good way to think about it.
Right. But if the end goal is exactly the same, just supporting the urethra, why does the material matter so much?
Because harvesting that cotton, so to speak, is a major surgical event all on its own. Let's look at the autologous pubovaginal sling first.
Okay.
So autologous simply means coming from the patient's own body. To get the material for the sling, the surgeon has to harvest a strip of fascia.
And fascia is like connective tissue, right?
Yeah, it's a very tough fibrous layer of connective tissue that wraps around your muscles. For this procedure, they usually take it from the rectus muscle in your lower abdomen,
Okay.
or sometimes from the fascia lata in your thigh.
Wow. So before they can even fix the incontinence, they have to perform a completely separate tissue harvesting procedure.
Yeah.
Our sources say this requires a horizontal incision in the lower abdomen that is roughly 6 to 10 centimeters long. I mean, that is a significant cut.
It really is.
Yeah.
It's essentially the size of a small C-section incision, going through multiple layers of tissue.
So because of that abdominal approach drawing, directly from the American Urogynecologic Society and the Society Urodynamics Guidelines, general anesthesia is an absolute requirement.
General anesthesia, or at the very least a major regional block like a spinal or epidural, yes. You are looking at a surgery that takes 1.5 to 2 hours to complete.
So local anesthesia is completely off the table for the autologous sling.
Completely off the table.
Wow.
And while full paralytic drugs aren't strictly mandatory for the entire procedure, the guidelines note that temporarily paralyzing the abdominal muscles really helps the surgeon.
Helps them do what exactly?
It helps them properly close that tough fascial layer back up after they've harvested the strip. The fascia is responsible for a lot of the structural integrity of your abdomen, so it naturally holds a lot of tension.
Oh, so paralyzing the muscle relaxes that tension.
Exactly, so the surgeon can suture it securely. Plus, because of the invasiveness, you are looking at a hospital stay of 2 to 3 days.
Yikes.
Yeah, and typically a catheter for at least a couple of days while the bladder recovers from the trauma of the surgery.
Okay, when you lay it out like that, I'm assuming patients choose this route because there's a massive long-term payoff. I mean, harvesting your own tissue requires a larger incision, general anesthesia, a hospital stay, and a longer recovery time.
Right.
The alternative is a pre-made synthetic sling in a quick outpatient procedure. There has to be a compelling reason someone would opt for the autologous route.
If we connect this to the bigger picture, it often comes down to the phrase, short-term pain for long-term gain.
Okay, how so?
Well, synthetic mesh slings are generally very safe and effective, but they have been the subject of controversy and FDA scrutiny over the past 2 decades.
Oh, right, the mesh lawsuits?
Exactly. A small percentage of patients experience complications where the synthetic mesh actually erodes into the vaginal wall or the bladder
Yeah.
or causes chronic pelvic pain.
That makes total sense. We've all seen those late-night commercials. People are naturally going to be wary of putting a permanent foreign object into their body if there is a risk of it eroding.
Absolutely. Though, to be fair to the synthetic options, the midurethral slings used specifically for stress incontinence have a much, much lower complication rate than the larger transvaginal mesh sheets used for pelvic organ prolapse.
And the prolapse mesh was what the vast majority of those lawsuits were about, right?
Right. But still, the risk isn't zero. With an autologous fascial sling, because it is your own native tissue, the risk of your body rejecting it is zero.
That's a huge peace of mind.
It is. The risk of synthetic erosion is zero. It's incredibly durable, boasting an 80 to 90% success rate at 10 years.
Wow, okay.
So for complicated cases, severe intrinsic sphincter deficiency, or for patients who are simply averse to having any synthetic material permanently placed in their body, the autologous sling is a phenomenal, reliable option.
But to answer the core mission question, it absolutely mandates general or regional anesthesia.
It does. There's no getting around it.
So, if harvesting your own tissue requires that level of invasive surgery in a hospital stay, it's no wonder surgeons in the 1990s started searching for an off-the-shelf alternative.
Oh, complete.
Which brings us to the other side of the aisle, the synthetic midurethral slings, or MUS. And these completely revolutionized the field, didn't they?
They really did. Because the mesh is pre-made, there's no tissue harvesting whatsoever.
So no large abdominal incision.
None. The sling is placed using specially designed introducer needles through very small incisions. Instead of a massive cut, they designed tools to thread the sling through the body's natural pathways.
Huge pathways.
There's the retropubic approach, where the needles slip up behind the pubic bone. There's the transobturator approach, which threads the mesh through the natural creases of the groin.
Okay.
And then there are the newer single-incision mini-slings, which only require one tiny cut entirely inside the vagina.
Okay, so here is where we explicitly answer the focus of today's deep dive for this specific material. Can these synthetic slings be performed under local anesthesia with sedation?
The answer is a resounding yes.
Yes. Looking at the clinical data for those single-incision mini slings, one study noted that a massive 72.8% of them were performed under local anesthesia.
That's right. The surgical team basically uses a combination of local anesthetic injected directly into the surgical sites to completely numb the pain, paired with intravenous sedation.
Which is often called MSC, right? Monitored anesthesia care.
Exactly. So you are relaxed, you are comfortable, you might even drift off to sleep for a few minutes.
Yeah.
But you are breathing entirely on your own without a ventilator.
Here's where it gets really interesting, though. Because choosing local anesthesia isn't just about avoiding the grogginess of general anesthesia or getting to go home faster.
Not at all.
It actually gives the surgeon a massive tactical advantage during the surgery itself. It's called the cough test.
This is arguably one of the most fascinating aspects of modern urology.
It's so cool. So picture the scenario for a second. You are in the operating room. You have local anesthesia, so you aren't feeling any sharp pain, but you are awake and responsive. The surgeon fills your bladder with about 250 to 300 milliliters of saline, and then, while they are literally in the middle of placing the sling under your urethra, they ask you to actively cough.
It sounds totally counterintuitive, right?
It really does.
You usually want a patient perfectly still during a delicate surgery, but this provides real-time, live, functional testing of the repair.
Because you're awake, I'm assuming you can actually give the surgeon physical feedback while they are tightening the sling. So it's kind of like tuning a guitar string, tighten it too much and it snaps or blocks the sound, leave it too loose and it doesn't do its job at all.
That is a perfect analogy. The absolute hardest part of a synthetic sling procedure is getting the tension exactly right.
Right, because as we mentioned, it's a tension-free hammock.
Exactly. If the surgeon makes it too tight, the urethra is obstructed. The patient goes into urinary retention, meaning they cannot pee at all after the surgery, and they end up requiring a catheter.
Which nobody wants.
Right. But if the surgeon leaves it too loose, the sling fails to support the urethra during exertion, and the patient continues to leak urine just like before.
So if a patient is completely paralyzed under general anesthesia, the surgeon is essentially flying blind.
Basically, yeah. They have to empirically guess the tension based on their past surgical experience. They often use a little spacer tool between the urethra and the mesh to try and get it right.
But under local anesthesia, because the patient can cough on command, the surgeon can see exactly what happens under real abdominal pressure.
Exactly. They ask you to cough. If a stream of water comes out, the sling is clearly too loose.
So they just adjust it right then and there.
Yep. They tighten the mesh just a millimeter or two and ask you to cough again. They do this dynamically until just a few drops of urine escape, which is the absolute sweet spot.
That is brilliant engineering.
Yeah.
You are actively calibrating the valve while the system is running.
It's amazing.
It minimizes the risk of over-tightening and significantly reduces the chance of surgical failure due to the sling being too loose.
It's a huge advantage.
But wait, I have a question. Being awake while someone operates on your most sensitive areas sounds terrifying to a lot of people, even with sedation.
Oh, absolutely.
So why wouldn't a patient just get a spinal block, like an epidural? You are completely awake, you can follow commands to cough for the test, but you are totally numb from the waist down. Wouldn't that be the absolute best of both worlds?
You would think so, but what's fascinating here is that the clinical data strongly suggests otherwise. Which brings us to the hidden risks of our anesthesia choices.
Oh, really?
Yeah. We have a retrospective cohort study in our stack of sources that looked at exactly this scenario. It examined 131 women undergoing outpatient mid-urethral sling procedures.
Okay.
And they compared women who received regional anesthesia, so spinal or epidural blocks, against women who received non-regional anesthesia, which included general anesthesia, and local with IV sedation.
And the outcome they were measuring was acute postoperative urinary retention.
Yes.
Basically failing the voiding trial before you get to go home, meaning you try to pee in the recovery room and you just can't, so the nurses have to send you home with a catheter.
Right. And the findings were stark. Women who received regional or spinal anesthesia had a 4.4 times higher risk of acute postoperative urinary retention compared to the non-regional group.
4.4 times higher. That's massive.
Yeah.
Looking at the exact numbers from the study, the retention rate was nearly 62%, specifically 61.9% for the regional anesthesia group, compared to only 24.7% for the non-regional group. So if you get a spinal block, you have better than a coin flip's chance of going home with a catheter.
It's wild.
Why is the disparity so huge? Both groups are getting the exact same surgical procedure.
Right, so this raised an important question for the researchers. And the answer lies in the specific nerves that a spinal block affects, and how long it takes for those nerves to wake back up.
Okay, break that down for me.
When you get a spinal anesthetic, the medication bathes the nerve roots in your spine. It paralyzes the motor nerves that allow you to move your legs.
Which is what you want.
Right. But it also paralyzes the autonomic nerves that control your internal organs, specifically the detrusor muscle.
The detrusor muscle being the smooth muscle in the bladder wall that physically contracts and squeezes the urine out.
Exactly. Now here's the biological quirk.
Yeah.
Spinal anesthesia wears off at vastly different rates for different types of nerve fibers.
Wait, they don't just wake up at the same time?
Nope. Studies have shown that the motor blockade, meaning your ability to physically move your legs, lasts for an average of about 148 minutes after a standard bupivacaine spinal injection.
Okay, about 2.5 hours.
But the detrusor blockade, the paralysis of the autonomic nerves controlling your bladder muscle, specifically around the S3 nerve root, that lasts for an average of 462 minutes.
Are you kidding me? 148 minutes versus 462 minutes.
It's a huge difference.
Imagine sitting in the recovery room. You can stand up, you can pace around the room, you feel entirely ready to go home, but underneath, your bladder is completely paralyzed and overflowing for another 5 hours. That is a wild biological quirk.
It really is. The patient feels totally fine. They can wiggle their toes, they can walk around, and the recovery nurses naturally say, okay, time to pee so we can discharge you.
But they can't.
No, because that S3 nerve root is still completely asleep. The bladder is full of urine, but the detrusor muscle simply cannot contract to push it out. The patient fails the voiding trial, and they are sent home with a catheter.
Wow. And it gets even more granular than that. Even within the non-regional group, the specific type of anesthesia mattered immensely, didn't it?
It did.
Because the study noted that general anesthesia with an endotracheal tube, where a machine is breathing for you, resulted in a 40% urinary retention rate.
Right.
But local anesthesia with IV sedation, only a 9% retention rate.
Which perfectly illustrates why local anesthesia with sedation is emerging as such a preferred method for synthetic slings.
It makes so much sense.
The choice of anesthesia isn't just about your comfort during the 20 or 30 minutes you are in the operating room. It dramatically dictates your recovery process and your risk of complications in the days following the surgery.
Because going home with a catheter isn't just an annoyance. It introduces a whole new set of risks.
Absolutely.
In that same study of 131 women, 25% of the patients who were discharged home with a Foley catheter ended up having to be treated for urinary tract infections within the first 2 weeks.
That's a quarter of the patients.
Yeah. Compare that to the women who went home without a catheter. Only 2.4% of them got UTIs.
So by choosing local anesthesia, you are really stacking the deck in your favor. You are allowing the surgeon to perfectly tune the sling during the procedure, you are waking up without a paralyzed bladder, and you are drastically reducing your risk of a postoperative infection.
That's just incredible. So let's bring it all together and summarize the mission of today's deep dive.
That's
The
good.
question was, can a sling procedure be performed under local anesthesia with sedation, or is general anesthesia a requirement?
The answer is yes. It can absolutely be done under local anesthesia with sedation. But primarily if you're receiving a synthetic mid-urethral sling.
Right.
Doing so offers major clinical advantages. It allows for the intraoperative cough test to perfectly calibrate the sling's tension, and it significantly lowers your risk of waking up with a paralyzed bladder and going home with a catheter and a potential UTI.
But if you and your doctor decide that an autologous fascial sling, the one made from your own harvested tissue, is the best route for your specific anatomy, or just to avoid synthetic mesh altogether, then general or regional anesthesia is mandatory.
Exactly. You have to be deeply asleep or completely numb for that tissue harvest.
It really highlights how heavily interconnected surgical materials and anesthesia really are. You cannot make a decision about one without fundamentally altering the other.
You really can't. They are a package deal.
Having this knowledge completely changes the conversation you can have with your urologist. And that brings us to a final thought I want to leave you with today.
What's that?
Well, given the fact that these single incision mini slings are increasingly being performed under local anesthesia, sometimes even in outpatient office environments rather than full hospital operating rooms, how might this shift our entire societal view of treating stress urinary incontinence?
Oh, it is a profound shift.
Yeah.
We're taking a major surgical intervention and turning it into something closely resembling an advanced outpatient procedure.
Right. And if fixing this incredibly common life-altering condition becomes as routine and accessible as, say, going to the dentist to get a cavity filled, could we finally erase the stigma?
That's the hope.
Going back to that opening image, you shouldn't have to walk around holding a bursting water balloon, terrified to laugh or sneeze.
Nobody should have to live like that.
If the barrier to entry for the cure is just local anesthesia and a quick office visit, maybe we can finally stop suffering in silence.
That is the ultimate goal of advancing these surgical techniques, making relief accessible, safe, and routine.
Absolutely. Well, a huge thank you to everyone who wrote in requesting this topic. We hope this gives you the clarity you need for your health journey. Keep those questions coming, and we will see you on the next deep dive.